Hi, everyone. Welcome to Please Excuse My OCD. My name is Tyler Falcoa, and I am your host. Today, I am super excited because I have my friend Alie here, Alie Garza, who is a social worker. She's a clinician with the OCD program at the University of Colorado and holds an MSW from the University of Washington in Seattle. Her clinical interests include providing neurodivergent-affirming care for comorbidities such as ADHD and ASD, working with youth and parents, and taking a think outside the box approach. She has worked in various clinical roles, including crisis mobile response, youth suicide prevention, and IOP, PHP, and residential for OCD and anxiety related disorders. Alie has lived experience with severe OCD and is passionate about mental health advocacy, especially demystifying higher levels of care and destigmatizing taboo themes. So, without further ado, Alie, welcome to Please Excuse My OCD.
Thank you. Yeah, thanks for having me.
I'm really excited to have you on because you are my second guest, and this is the first time I'm doing it, via Skype, which is pretty cool. So, I came across your page on Instagram, and it was actually when I first started um, Please Excuse My OCD, and I was looking for people to just connect to and see what they were about in the OCD community
Mhm.
and learn a little bit more about what kind of conversations are happening there. And of
Mhm.
course, you were super kind to reach out and just really be, at the forefront of that for me. So I appreciate that.
Yeah, thanks.
But for people who are just hopping on and checking this out, can you just share a little bit about yourself with me and your journey with OCD and where you are now?
Yeah, I'll try to make it kind of a snapshot because it's been quite the journey, as you can probably imagine.
Of course.
But yeah, I live in Denver, Colorado. I grew up in Boulder, but went out to Seattle for grad school, then down to Portland before coming back this fall. I am a clinician. I'm on faculty with the University of Colorado, and I work for their OCD clinic. But before that, I've worked in OCD for a couple years, and even before that, my clinical experience is mostly in crisis intervention and working with teens. So I'm one of those cases that luckily we're kind of seeing less and less of people who have had OCD symptoms since they were like in middle school. For me, it was true to form in eighth grade where my symptoms came up. And then I went from eighth grade until I was about 25, 26, before I even heard about what ERP was. This was, never through my years in grad school or all those years working in the field had I ever heard about ERP. Um,
Wow.
and so I went about 15 years, give or take, being misdiagnosed, receiving basically every type of treatment aside from
Mhm.
ERP, and watching myself get worse and worse and worse. So when finally my symptoms hit a peak in the spring of 2021, and I needed to seek residential treatment, that's where I actually was exposed to ERP for the first time. And then after going through treatment, I made a quick career shift from crisis work to OCD because after going through it myself, I couldn't imagine doing anything else as a clinician. So yeah,
Mhm.
that's just a snapshot of me.
Wow. That's so true that OCD has such an impact on us when we go through it personally that it really is hard not to be changed in some way,
Yeah,
And so it sounds like you found a more focused direction because of what you went through.
absolutely. And I think I was talking to a coworker a couple weeks ago about I don't know what it is, but like OCD is like one of the only kind of clinical niches in which I've seen such a high prevalence of clinicians with lived experience. I think another one is like substance use disorders. You see a lot of folks with lived experience.
Mhm.
But I just see, yeah, there's a huge prevalence of providers who are like, I've been through this, I continue to go through it, and this is what I do for work too. So I think that's something that's really unique about the field.
Yeah, it's I think because it's so treatable, but it's
Mhm,
also extremely hard for the sufferer to endure that and see that. So when you do get out to that other side and you're able to look at it from a different perspective,
mhm.
yes, you can bring more to the table when you're helping someone. And in terms of like, you said something that rang true to me because you said you were misdiagnosed for 15 years.
Mhm.
What were like, from the clinician's point of view, what were they diagnosing you with?
Oh, a little bit of everything. I mean, I think that's the tricky part is that as my content evolved, so did, like, people's clinical perceptions, and so,
Mhm,
I mean, I've been diagnosed with, like, lots of things from they did GAD, just generalized anxiety disorder, and then, oh, is it like, I mean, disorder actually became true.
mhm,
Um, for a while, like a significant amount of time, I was misdiagnosed with bipolar 2. And
mhm,
I'm very curious about how many other folks are out there that have this interesting merge of having ADHD, and having an anxiety disorder or having OCD, who
mhm,
are misdiagnosed with that, people see their ADHD symptoms and they see their anxiety symptoms and they're like, oh, this is mania. But actually, like now as a clinician myself, I go through the criteria and I was like, this isn't what I said I was experiencing at all. Like I was sleeping, I wasn't doing these things, I wasn't
mhm.
acting in ways that I normally wouldn't. And so, yeah, just in my opinion, just some terrible
Wow.
diagnostic choices that changed the medications I took, it changed the
Mhm,
treatment I took, and like also how other people supported me. I think you can probably appreciate that, and if people don't understand that it's OCD and they call it something else, it gets really easy to kind of nosedive into accommodating behaviors, right?
yeah,
Um, so yeah,
like really just, reassuring you and kinda going down that rabbit hole.
yep,
Yeah.
absolutely.
That's it's really, really interesting to me that, because there's a lot of parallels with my life that I'm connecting to while listening to your story, because I got diagnosed at the age of 10 with OCD, but I was not lined up with, um, therapists who were specialized in OCD.
Yeah.
So I jumped from theme to theme, not realizing it was OCD, and it wasn't until I was, like, 20 years old where I went to my physician with, like, my worst theme of all, which was harm OCD,
Hmm.
and he was like, "This is OCD, like, you're diagnosed with OCD," and I was like, "This is OCD? Like, you're telling me it's not just being clean? It's not just,
Yeah.
I had the same stigma in my head
Yep.
growing up because of that."
I had the exact same experience as far as like when I had my so I was initially in 8th grade diagnosed with OCD because it was very
Mhm.
much so around contamination.
Yes.
Um, but that for whatever reason, that's the only kind of contamination phase I had. And so then in
Mhm.
high school, when it shifted to harm and health, absolutely off the radar. It wasn't even on the diagnosis list. It was like, oh, this is irrelevant. Like she doesn't have this anymore. I mean, I'm
Wow.
so when I hear that you had like a physician, it sounds like a primary care doctor
Mhm.
who said like this is what that like, that's miraculous to me. Um,
Yes.
as you can probably appreciate, there's so many mental health providers who don't
Mhm.
understand that, psychiatrists, so to have a
Mhm.
primary care doctor be like, "Hey, Tyler, actually, this is what's going on," I think is so incredible, and my hope that, like,
Yeah.
that becomes the norm over time, right?
Yeah, because it is so misunderstood, and the fact that, like you said, it was a literally my physician he was my childhood physician. I had him until I was 21, and he was like, we're gonna try you on some." That was the first time I got on medication.
Mhm.
So, it's kind of wild how there's so many people who are part of the mental health field in general that don't understand OCD, because it really is hard to understand if you haven't really been through it too.
Oh, absolutely, and I think or have a loved one who's gone through it, and I think that's why there's such a prevalence of OCD providers that have lived experience or know someone in fact, I kind of ask myself sometimes when I meet new folks who don't have lived experience, I'm like, "Oh, how did you get into this?" Because it's almost like this interesting niche that isn't as widespread as some other types of practices or
Mhm.
modalities, so I'm always interested to hear people's stories, and it's usually like, "Oh, I stumbled upon it with this internship or with blah, blah, blah." Um,
Wow.
so yeah, I think that's an interesting aspect that you don't see with other
Yeah.
modalities and treatments, so
Do you sorry, I'm, like, really interested in this. Do you feel that there's a specific or, like, a multitude of reasons why OCD is so misunderstood from that perspective? Or do you think, like, maybe even the fact that there aren't as many people with OCD who are going into that field What do you think is like the biggest thing that is the confusion point?
Um, that's a great question. I have a couple theories of, like, pieces.
Sure.
Obviously, which is really sad, but I feel like the media portrayal of OCD has leaked into how providers view OCD.
Mhm.
So I feel like it's not too challenging. In fact, I feel let's say it's pretty uncommon for people who have contamination just right to be misdiagnosed, right? I think
Mhm.
the average clinician can pinpoint that. I think, and it sounds like you have similar lived experiences with harm OCD that I do, that
Mhm.
the average mental health professional is very well versed in, like, okay, this is how we screen for, these risk assessments and this and that. And then we send them, we do the, intervention, send them to the hospital, yada, yada, yada.
Mhm.
That nuance of being able to understand these other themes, I feel like is not taught in almost any program. And then the practicum placements in which people would learn these things, I mean, are far and few. So I think it's just like this sad disconnect between programs, school,
Mhm.
training, and them being maybe more focused on certain diagnoses like major depression and,
Yep.
screening for suicide, and so those are all valid and important, but I think then it gets very murky when this like harmosity and other things are being way underrepresented and under trained on. So
Yeah, and it's so important too because if I was lucky because when I went to the doctor and I said I'm having these thoughts of like hurting myself, he automatically knew it was OCD because of my prior diagnosis.
yeah,
Think about it from the perspective of a doctor who hears that from someone who isn't formally diagnosed with
yeah,
OCD and how dangerous that could be to be like, "Oh, let's just send him to a hospital, maybe get the cops," and like,
yep,
you know what I mean? So that's really dangerous to not have the knowledge of the fact that the people who have OCD and they're suffering from these kind of intrusive thoughts, they really are going against what they actually want.
yeah.
And so that's the hard part is to when somebody is presenting themselves with these thoughts and going to ask for help, how do they not make it worse?
Yeah, I mean, it is such which is so sad, but it's really
Mhm.
just like a run like luck, right? I think the
Right.
fact that your provider knew that is
Mhm.
amazing, and
Yeah.
I've had the opposite experience of, disclosing my harm OCD symptoms and being told I'm a dangerous person, that I'm a liability, losing my job, and so
Oh my
and I've
gosh.
seen other folks that have had really horrific outcomes of disclosing their symptoms to people that don't have the education or the understanding and aren't willing to learn,
Mhm.
um, and it going really poorly. I think that's why I'm also so passionate about advocacy is that I'm I mean, from that specific incident, that was in 2016, so I'm several years out from that now, and it still impacts me to this day.
Sure.
That's also why it's so important for me to share this is because it is a risk, advocacy
Mhm.
and sharing your story. I've seen what happens when I've shared, pieces of my journey and it's completely backfired.
Mhm.
And I feel much more comfortable now, as a provider and as someone who's talked a lot about my story, sharing it and taking that risk. But even to this day, it was only like a couple months ago that I was in an appointment with a new, like psychiatric nurse practitioner who, as I was explaining harm OCD, as like from the perspective as a provider, talking
Mhm.
about my experience, I could tell she was like confused and didn't want to
Wow.
believe me, and it makes me still on edge to this day.
Mhm.
Uh, and I'm willing to do it because my hope is that it will spread awareness, spread
Mhm.
education, and inspire people to wanna know more, so they can do
Right.
better, right?
Right.
So, yeah.
That's incredible because it takes a lot of courage to talk about these things in general, never mind in public like this. This actually helps me feel more comfortable that you're talking like understand this and you've been through the same things.
Mhm,
And if we could really look into the heart of someone with OCD, if people could really see into the heart of someone with OCD having those kind of painful, intrusive thoughts, they would
mhm.
realize that they are the least dangerous people in the world. Like they are the least dangerous type of people because they want the exact opposite of what they're thinking about. And that's
Yeah,
why it bothers them so much.
yeah, I had a
Um,
therapist once who was like when I was in the peak of my harm OC around driving, right?
mhm,
And kind of like my conceptualization of doing ERP and like the concept of uncertainty
Mhm.
is less so like, "Oh, maybe I'm gonna do it," like, being okay with if I did it, but more so trying to, like, get myself and my rampant OCD to get to a point where I'm able to accept that the level of uncertainty that I'm feeling or that is the case for me is also the case for anyone else, so
Mhm.
I'm just as likely as my therapist, as my dad, as whoever, anyone off the street to act on these intrusive thoughts,
Mhm.
and I remember her telling me one time, she's like, "Well, I mean, for being honest, like, statistically, you're probably actually way less because you don't drive." I was like, "Huh, point. I don't wanna stay at that low statistic. That's tempting. Trust me,
Mhm.
but, like, actually, weirdly enough, like, your life is so debilitated by avoiding these situations that probably statistically you're a little less."
Yeah.
Um, so trying to get up to a normal level of risk taking, right?
Wow.
So
So just to speak on that a bit more, because I really want this to be personal about you too, rather than the field itself, but you said you were avoiding driving because of that?
oh, yeah. I mean, that was in 2016. I had a
Mhm.
huge, like, the worst onset of sudden content shift,
Mhm.
and it was horrific. I mean, I, out of absolutely nowhere, was driving down the road and suddenly had the intrusive thought of, "What if I swerve right now?"
Yep.
And from that point forth, my life was not the same.
Wow.
Um it escalated in true form. I didn't know ERP. I didn't know anything about like, yeah, what do I do now?
Mhm.
Um, and so it went from, not driving to only sitting in the passenger seat to only sitting in the back seat to sitting in the back seat with my sitting on my hands
Mhm.
to closing my eye. Like it just continued to escalate to the point that I just became agoraphobic. I was like, I can't leave unless I'm walking.
Right.
Um, and then just as incidents came up, the content just spread. So it went from
Mhm.
like driving to um then I went on a trip with my sister to San Francisco and suddenly it became escalators. That I'm gonna throw myself off the escalator. I'm gonna blah
Yep.
blah blah. And it just continued to escalate. And I think what's fascinating about my story is that with the driving, like when this all happened, I got to the agoraphobic point and I was like, "This is not gonna work." So what I decided to do, um, was wake myself up every day at 3 AM
Mhm.
when no one else was on the road and basically do exposure therapy. What's important to note is that I was doing exposure therapy. I wasn't doing ERP. There was no response prevention.
Mhm.
I was just simply getting in the car, sweating head to toe, panicked, and just forcing myself to drive. Um, but while I was doing this, I was engaging in nonstop compulsions, praying out loud, listening to this one specific sermon on a loop, uh,
Mhm.
like everything you can think of. I was pulling all the stops, and I had no awareness that that was harmful. My thought was like, "Oh, if I just keep doing this,
Yep.
eventually OCD will lessen up."
Right.
Um, and I guess eventually, somehow, with like putting myself through a pretty hellish habituation, heavy exposure
Mhm.
process, I drove, but then in true form, it came back, right? And so
Right.
that's why I like to really specify the difference between doing exposure versus ERP. That if you're not doing response prevention, there's no use. It
Mhm.
doesn't have any value. So that was my way of taking on my OCD was through the night,
Wow.
driving through Boulder County.
Yep, that's incredible. Because like, I would love for you to just describe, what response prevention entails, because I've never done ERP. I've done exposure to
Mhm.
myself, which made things a lot worse,
Yeah.
but I've never been actually working with someone who was in RP. So and I understand, but for the viewers, I'd like you to just go into detail about the difference between that and just, added response prevention on top of that.
Yeah, absolutely. So there's kind of some key pieces in how exposure therapy slash ERP has evolved through the years. So first, there's like the difference between exposure and exposure response prevention. So for example, when I'm driving, right, if I was just doing exposure, I'd be doing exactly what I did for weeks through the night
Mhm.
of driving, but then praying out loud, having to listen to the same sermon the whole time, doing these things. The problem with that is that it's reinforcing the very OCD cycle that says, if I do this, I will prevent something bad from happening. right?
Mhm.
These are my means, my, as I like to call them, illusions of control. Of if
Mhm.
I do these things, I will be safe, or at least have a greater shot of being safe. And in true form, while you're doing the thing you're scared of, you're also reinforcing that, like, I can't handle this. It's dangerous. It's too much. So I need to do these things to be able to get through it. So how that changed is that then when I did ERP with like response prevention, I started a lot smaller to ensure that I could do the exposures with response prevention. So let's say I'm in the car, right? And I notice myself like doing some sort of mental checking or reassuring. That's the
Mhm.
moment I'm like, up. And response prevention means that I'm going to redirect my attention, not like shove it away, like allow the intrusive thoughts to be there, be like, shocker, the same
Mhm.
intrusive thought I've had for 10 years, here it is. And instead be like, and I'm going to direct my attention to this conversation. I'm going to listen to the music, not to prevent the intrusive thoughts from coming, but rather to redirect what my brain wants to do, which is ruminate, check, etc., to like
Mhm.
engaging in the moment.
Right.
Um, and that's trial and error as far as like what types of response prevention work. People talk about like non-engagement statements. So like, which I love because you get to be
Mhm.
snarky. So like, my favorite is like OCD giving me intrusive thoughts and being like, yeah, never heard that one before, or some version of like shocker. I'm
Yep.
gonna swerve. You don't say. It's not like I've
Mhm.
been that since,
Yep.
school. And so figuring out ways to kind of, yeah, not shove the intrusive thoughts away, but also not cling to them for dear
Mhm.
life, if that makes sense.
No, that makes perfect sense. So really just, it sounds like it's the awareness of, uh, those compulsions and doing what you can to make sure that you don't do them.
Mhm. Redirecting your attention from, like, I think if I really big picture it with ERP, it's like, okay, look at the things that make me anxious and what are the things that I might be doing overtly or maybe more sneakily to
Mhm.
try to minimize that anxiety and do the opposite, right? Which is very, very challenging on the front end. But then once you start to notice the traps, just like intrusive thoughts
Mhm.
content tends to be consistent in some ways, so do the traps. So you become kind of more and more aware over time of like, yep, this is an OCD fan favorite. This is not my favorite experience, and this is what I'm going to do next, despite that. So,
Yeah. That's really insightful, and it's really interesting how you because it's so sneaky, your compulsions, and we can have, mental compulsions and physical compulsions.
mhm,
In most of my life, I performed both, but I did not realize that I had mental compulsions until like 2 years ago, and I'm 29 years old.
yeah,
So, like, I would have the word "dye" pop up in my head, and I would finish the sentence with, like, "Dye my hair blonde."
mhm,
And to avoid that uncomfortable feeling of, "Oh, I keep saying 'die' in my head." Um, it's really and I hadn't known that, like, it became so habitual that I didn't even realize I was doing it,
mhm.
throughout my life.
Absolutely. I give major credit to my first ERP therapist that I had in Portland when I did my intake. My first ERP session, she's like, "So tell me about the compulsions that you engage in." I'm like, "Oh, I don't have compulsions. I just, just upset, blah, blah, blah." And I think that's
Yeah.
where like the term pure O comes from.
Mhm.
But pure O, I like to call a gateway term where it's like, and it's just OCD.
Right.
You have to have compulsions to have OCD, whether those compulsions are internal or,
Mhm.
or versus external doesn't really matter. It just makes it a lot trickier sometimes because, seeing someone wash your hands, it's like, oh, clear as day. But like those mental processes, like people wouldn't know that you're saying like
Right.
my hair blonde. And
Right.
similarly for me, like people wouldn't know. And if it becomes a way of life for me, it's like, oh yeah, of course. Like every time I have this intrusive thought, I'm just gonna, spout out freaking Hebrews
Mhm.
6:19 to try to like neutralize
Yeah.
thought.
Yeah.
And so it becomes so normal.
Mhm.
But it's still compulsions. It's still some way of trying to reduce anxiety. And so, yeah. And similarly, I went through that whole intake, dead set on no, no compulsions. And then like a week
Wow.
later, I mean, definitely a couple months later, I was like, oh, queen. I'm so shocked you didn't laugh at me because I was riddled with compulsions. So
Yeah. And she probably knew that.
yeah.
you know? And so when you went to ERP for the first time,
Mhm,
can you can you talk about, like, what I'm sure you had a tremendous amount of fear because you know that you're going to be exposed to your fears.
mhm,
Can you kind of give me a night and day snapshot of, like, before you went into it and after you finished? Are you finished with ERP?
it's a lifetime experience for some of us, but no,
Yeah.
yeah, I would say that once I left residential, I've continued doing outpatient therapy, but as far as how much of my therapy actually is ERP, it's pretty minimal because it's like, I know what to do. It's
Yeah.
more so just in those moments, kind of navigating the nuances of, like, how to apply it.
Mhm,
But absolutely, any outpatient provider I've worked with since then and in the future will be OCD informed and ERP trained because they
mhm.
need to understand that lens. But yeah, as far as like doing active ERP, like as therapy homework, that's not been the case for a long time for me.
Wow. I mean, that's great. That's a great thing.
Mhm,
I, um I feel like people who are watching this who may be afraid to take that step. Maybe there's people who have OCD, they know they have OCD, but they're still afraid to go forward with doing that kind of therapy.
mhm.
What is something that you would tell them?
Yeah, I find it so fascinating. Even amongst providers in the field, there's so much misunderstanding and almost stigma around ERP that's like, "Oh, yeah, you're just" I think they're truly picturing, like, you just put someone in the room who's scared of spiders and you have them touch the spider all day. And
Mhm,
when people who have that perception of it, I'm like, that is the farthest thing from the truth. I mean, yes, there's an aspect of exposing yourself to things you're anxious about, but I
mhm,
think what's missed is the real kind of like foundation of ERP is understanding, the processes, the mental processes that come into play. What we were talking about with like that's very habituation heavy. And
mhm,
we're veering way more in the field towards inhibitory learning about it's actually not about touching the spider 100 times. It's about your relationship with anxiety and your relationship with fear and your willingness to experience it. Um, and so I've had a lot of people that have either had not great ERP that's been very kind of systematic and very habituation based. And then typically we see that in true form, OCD just, comes up with new content and they get the rug ripped out from underneath them, right?
mhm.
But I would say that finding a provider that is specialized, that has the experience, which is a challenge in itself. I did a slightly unhinged thing, like a year ago where I went through on Psychology Today for
Yeah.
the Portland metro area, and I marked OCD, and I even took it a step farther, okay? I marked providers who treat OCD and are trained in ERP, and there
Mhm.
was probably like 30, 40, and then I emailed them all and was like, "Hey, looking for blah, blah, blah. Can you tell me about your experience?" And I wish I was joking, Tyler. Of that list, more than half were like, "Oh, I actually have never been trained in this. I don't know, blah, blah, blah." And I'm like, "You are making this like as if it's not challenging enough to navigate this field. Like if people are not upfront or not honest about the types of training and experience they have,
Mhm.
and that makes it challenging. So really going like looking into like, okay, and tell me about how many patients with OCD you've treated, what are your modalities, where were you trained? We shouldn't have to do this, but sadly
Right.
we do, because the mental health field does not do a fantastic job of like, clarifying specialties like
Mhm.
medical does, right? We would never need to get brain surgery and go to an orthopedic surgeon, and yet it happens
Right.
all the time in the mental health field, except
Wow.
people think that they're getting care that's effective. And so,
Yeah.
yeah, really like clarifying, like, okay, knowing your terms, like, are you trained in ERP? Where did you do that? Tell me about like, yeah, your modalities, your practice, blah blah blah, and making
Wow.
sure that they're a good fit. And then, of course, I like to say also that finding a therapist is like dating.
Yeah.
Um, Psychology Today, it really feels like Tinder, where you're just like copy paste the message, send it to the
Yeah.
this, hope someone responds. So really not like expect that the first therapist very well will not be a good fit.
Mhm.
If they are, fantastic, but like really kind of like seeing who's a good fit for you. If you need someone more flexible and creative, great. If you need someone who's like going to sell it to you straight and you know
Mhm.
that, finding the right fit takes time sometimes, so
Wow. It sounds like it really is funny that you said it's like dating. It's like trying to figure out, well, what are your values here? Like, what are your credentials, you know?
absolutely.
Um, that is wild. And I understand that too because I my whole life I've been with therapists up until the one that I have now. She's incredible and she understands the how my brain works, and I've been working with her for 5 years, and
Mhm,
she's helped me really learn to not engage with the thoughts and really just let them be what they are.
mhm.
But prior to her, my whole life, I never had anybody who was trained in OCD,
Oh, yeah.
which is just it's wild. So when you think about where we are now, as opposed to like 10 years ago, 15 years ago, do
Mhm.
you see a difference? Do you think social media plays a part in that too?
Absolutely. I mean, listen, I understand, like, that there is lots of the adults in the world absolutely hate social media, and they,
Mhm.
point to it as, like, the means of all evil in some ways. I mean, I cannot tell you, Tyler, how many conversations I've had in my crisis days where, we're talking about a teenager to parents about their child's, suicidality, and,
Mhm.
their first response is, "We gotta get rid of the phone."
Yes.
It's like, "Okay, hmm. Okay, yeah, I mean, I totally agree, and the research backs it as far as, like,
Mhm.
how social media is unhelpful, but I wish that people would be able to practice more nuance with, like, and let me tell you about my high school experience where none of those things existed. I think Instagram was, like, barely out there,
Yeah.
um, and Facebook was not, like, the way it is now,
Mhm.
and what was the consequences? I had no way of connecting to other people. I
Mhm.
was dealing with insanely intrusive, robust, intrusive, taboo thoughts. I had no one like, I was literally scouring the internet, searching, thought about yelling this, thought
Mhm.
about starving, thought about doing this, and
Yep.
I was getting nowhere. And now there's so much information, so I think if it's a spectrum, right? Like, even not that long ago, when I was in high school, it was like there was nothing out there and no means for communication, and it was a very isolating experience that prolonged
Yes.
me getting evidence-based care for over a decade. On the other hand, of course, now it's like we're flooded with information and content. How much of it is actually evidence-based and well thought out?
Mhm.
Hard to say. But I think it's just now a matter of, like, managing, yeah, all the content that's coming in and the information, um, and how that's going to enter, like, the therapeutic relationship.
Yeah.
Um, I was just talking to another coworker who said she went through a training about this exact topic of, like, self-diagnosis among young people, and that in
Yep.
this training, they were telling her, like, "Oh, you should pull out your DSM and go through it with your clients." And I was like, "Oh, that'd be a bit of a rapport killer." Like, "Okay, yeah, let's just crack open the DSM together and, like, show you dot by dot why you're wrong."
Mhm.
I think there's more nuanced ways and, like, helpful ways to be like, "Okay, great. You resonated with this piece. Could mean a lot of things. Let's look into it together," rather just being like, kind of like what some people might say, where it's like, "Oh, everyone is getting diagnoses from the internet," you know?
Right.
I think there's
Right.
opportunities that come with that and, of course, pitfalls, so
Mhm. That's so interesting that you just laid that out as a spectrum because it truly is based on what you're getting out of it and how you use it. And I feel like I've learned more on social media about my OCD than I have growing up in therapy.
Oh, yeah.
And
Absolutely.
just from like seeing creators like you and people who are sharing their truth and being able to like use comedy in your own way
Mhm.
because it's hard enough to be serious on something that feels extremely serious anyway.
Mhm.
And comedy is something that I use as a coping mechanism. And so, like, if you were looking at the content you make now, if you were looking at that 10 years ago, do you think that that would have helped you in any way?
Oh, yeah. I was scouring the internet looking for anything like that. I mean, I was even just looking for, like, whatever it wasn't Reddit back then, it was, like, Ask FM or even before that, like, Google Yahoo Answers. I was scouring Yahoo Answers looking for anything, which is sad.
Yes.
That's what I had to work with, so, um
Same, same. And that's a compulsion too, right? It's
oh,
that reassurance.
yeah, I was a a frequent flyer on
Yeah.
Yahoo Answers, and that evolved through the years, you know?
Sure.
But yeah, no, I mean, I was so desperate to find anything and anyone that could tell me that what I was experiencing wasn't crazy, that I
Mhm.
wasn't dangerous, that and I didn't, like, meet anyone that had OCD, especially the way I do, like, with taboo themes, until I went to residential treatment. I was
Wow.
26. And so talk about an isolating experience, right? So I spent so many years just trying to like explain myself, sometimes it going okay, sometimes an absolute flop that was really painful, you know?
Mhm.
And so that content out there, I feel like would have made me A, feel less alone. But B, what I really hope for with the content is that people then take that and are like, huh, that's food for thought. And
Mhm.
where can I go with this? Like, this resonates with me. Let me take this to my therapist and be like, "What do you think?" You
Mhm.
know? It's kind of like a springboard. I feel like that's how a lot of things that I diagnoses and things that
Mhm.
I've had, have come to light is I get, like, a piece of information, and I'm like, "Okay, let's look into it." Where it gets tricky is then if you get sold on something of like, "No, this is the reason. This is it."
Mhm.
Um,
Mhm.
and so it's an opportunity to practice some flexibility, you know, uh,
Wow.
when those things come up.
Sure. And that it's so it sounds like it's even like a catalyst to keep the conversation going with people who have OCD, people who don't, and also clinicians who are practicing that.
Yep, that's my hope is that, like, people who have OCD get that kind of, like, a piece of something like, "Oh, this really resonates with me. This really looks my like my day-to-day life," and they take that and are like, "Oh, and this is where you go for evidence-based care. These are the things, the
Mhm.
acronyms to Google," right? And then people that don't, you know, I think there's so many disorders on the spectrum of OCD disorders and then also, like, anxiety disorders that there's a lot of overlap, right?
Mhm.
Maybe it's another diagnosis. But even then, if just people like when I post about, harm related content, my hope is that it becomes more and more normalized, even to people that don't have it, of like, Allie
Yep.
just posted this thing about how she's thinking about throwing herself over a railing every time she goes to work because she's on the fifth floor and there's clear panels that like even though I'm joking about and putting out there, it's like, and that's something that people with OCD experience sometimes. That's
Yeah.
my with that. So
Yeah, I experienced that with the because we have a bridge here in town, and one of my friends in college, jumped off and obviously, like, killed himself, and
mhm.
that was a huge trigger for me
Yeah.
with my harm OCD, so every time I went over the bridge, I'd have a panic attack being like, I could totally
Yep.
just turn the car so people have everyday people may have that thought, but it's just like, "Oh, that's" they don't get involved with it,
No. Yeah.
where it's
Yeah.
sorry about that, go ahead.
Oh, I was just gonna say, and I think like what you said with like your friends, it's like, and a lot of this content isn't just out of the blue. Like I've
Right.
also had a really close friend to me who died by suicide a couple years ago. And like
I'm
the
sorry about
way
that.
that happened and how and how that impacted me absolutely, like, kind of planted these seeds in my head, or
Mhm.
you read something and you're like, "That's horrible and devastating, I would never want that to happen," and then OCD takes it in, like, a baton race, it's just like and runs with it, right?
Right.
And so I think it's important also that people validate, like, yeah, and there's sometimes some really horrible life experiences and trauma that we've been through that OCD then wants to latch onto and run with. It's not all black and white, right?
Right.
Yeah.
It's and noticing that OCD can really run with anything,
Oh, yeah.
any theme. Like I've had religious OCD, existential, relationship, harm, contamination, health, like
Yep.
you name it. If it's a value of yours, it will be there.
Yep. Absolutely.
Um, and so also something I want to really reiterate too is it's not the theme itself,
Mm.
right? It's the reaction to the theme and the cycle that we stay in. And do you think that there's any theme that is, like, the worst theme to have or, like, the hardest to work through? Or do you think it really is from, like, an objectable point of view that they truly all are the same, it's just our reaction to it?
I love that question because it's like an ongoing debate, like, as far as
Yeah,
when I with my OCD friends, right? And I
yeah.
feel like this is true for everyone. Everyone's gonna say, "Oh, no. This is the
Mhm.
worst. This con" and I experienced this myself, like, when I was going through health OCD, I was like, "Oh my gosh. just give me the harm back. Like,
Yeah.
then you get the harm, like, oh, the health wasn't that bad, you know? So I
Right.
think when it's your content, whole different ballgame. You can look at someone else, like I've had this experience with my friends who have contamination. I'm like, I don't get it, you know? But you kind of have this laser focus on your own, and kind of blinders around it. I
Yeah.
think that any content can be severe, it could be mild. It's really about how much it's debilitating you.
Mhm.
I think it also is really important to note that, like, and I've never received, like, I've never been told with relation to my health OCD that I am a dangerous person, right?
Mhm.
Harm OCD, absolutely. I think there's some layers of stigma, some layers of, yeah, risk, misunderstanding of, like, I would never be afraid that if I disclose my health content, that I would end up being in an inpatient unit. That is very much so a fear with my harm OCD. And so I think
Mhm.
being aware of, like, how society understands or doesn't understand. I know this is especially the case for a lot of people with POCD, right? And you see the comments, you see the things from people who A, don't understand and don't want to understand.
Mhm.
And I think that's an added layer that's really important to
Of
um,
course.
be aware of. I don't think it's any less treatable at all. I think it's just like, and that's something that sometimes comes with a lot more pain, trauma, and consideration when going through
Mhm.
treatment. So.
Were you ever met with that compassion and empathy or just understanding, when talking to someone about your harm OCD? Was there anybody that really just met you there and were like, "I get it."
I think that's the hard part is that there was no one in my world that did get it. I didn't even get
Mhm.
it. I was, like, trying to understand it myself, me and Yahoo
Mhm.
Answers, right? And that was not a good combo, and so I really think one of the most reassuring, which I know we don't use that word in this field very often, but
Mhm.
when I went to my first outpatient appointment, that was January 2021 with my ERP therapist in Portland, and I, like, was like I just at this point, I had nothing to lose. I was just like, "Oh, yeah, da, 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 da," and
Yeah.
I'm
Yeah.
spouting off all these things about these horrific intrusive thoughts, and she's
Mhm.
like, "Oh, okay, cool."
Yep.
There's nothing
Yeah.
more reassuring for me and just like, like, I think people are so scared to talk about the
Yes.
content, and I totally understand why. Trust me, I've
Mhm.
lived it. But I think when you meet with someone that has either lived through OCD or lived with someone who's gone through it or a provider, there's like it feels like you can just take a breath, right? When you're like,
Yeah.
"Oh, I just spouted off all these things that are my greatest fears that I'm so scared they're gonna send me to jail or do this, and
Mhm.
the person's response was, "Oh, cool. Sounds good." I'm like,
Yes.
"Yeah." So,
I get it.
yeah, it's a huge relief.
That the reaction is so important. The
Yeah.
reaction of somebody who's talking to you is so important because, like, the first time I said "fuck," like, I think I was, like, 6 years old, I asked my dad what it was, and his reaction of, like, "What? Like, never say that again." I was like, "Oh
Mhm,
my god, I'm going to jail." But his reaction to that was like, "Oh my god," and I couldn't stop saying it in my head, and
mm,
that was, like, super bothersome. So
yeah,
whenever I talk about OCD, I try to also tell people, like, the reaction from the person that you're telling
mhm,
is also something to be aware of because if they understand it, it's one thing. If they don't, you just try to be careful about who you talk to about these things.
exactly, and that's like that situation I was in a couple months ago where I had an appointment with, and I was meeting with a nurse practitioner, not in the OCD realm at all, and, she's going through the Columbia, which is always, like,
Yeah.
a minefield with harm OCD when you're going
Mhm.
through these suicide assessment because it's, like, it's structured so terribly where it's like, "Have you had the thought of" and I'm like, "Yes." I've had
Yeah,
like, it's a
of
nightmare
course.
for harm OCD. But
Yeah.
yes, I'm going through it in true form. I'm like, she's asking the common question, "Have you had this?" I was like, "Yes, but I have harm OCD and blah blah blah." And I could see the like hesitation and the like, "Well, what do you mean?" Blah 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 blah. So are you going to act on it? Like the almost like suspicious.
Mhm.
I know it's like she's confused and she's trying to assess if I'm in a danger to myself, but that
Mhm.
is so reinforcing to, like, my OCD's fears of, like, "Yep, see? I'm a dangerous person." So, as
Mhm.
much I mean, I know there's some way less, ability to, have a poker face when you're a loved one and you're learning for the first time, but as much as possible, I mean and at this point, like, not a lot shocks me. So,
Mhm.
I literally will respond to when someone tells me, "Oh, I'm having this intrusive thought," like, "Oh, okay, cool, great. Good to
Mhm.
know."
Yeah. Thanks
'Cause
for
I
that information. That's good that you're at a place though too, where like anybody can really say anything to you, and you'll be like, all right, like I'm not judging you,
Yeah.
so it kind of opens up your empathy and your compassion. Even I mean, I know people who have OCD are really empathetic people at the core,
Mhm.
which is why I think they feel so deeply on the things that they are afraid of.
Yeah.
When I wanted to ask you too, like you talk about demystifying like the higher levels of care,
Mhm.
and like what would you say are some common misconceptions about those higher levels of care for OCD, and how do you address those?
Yeah, I think there's and OCD folks, I can relate to this as well. Making a decision like doing a higher level of care can be very challenging when you have OCD and are struggling with rumination and challenges with decision making.
Mhm,
And you're making a decision to, usually put your life on hold to do treatment, and then you're gonna have these OC providers who you're gonna be people always ask the same questions. I ask them, like, "Okay, how long is this gonna take? How much better am I gonna feel? Tell me,
mhm,
like, give me the timeline," you know? And, "Okay, am I gonna have this or that?" Um, and OC providers in true form will give assurance or, like, information, but we're not gonna be like, "Oh, yeah, you'll be great. You'll be fine, blah, blah, blah." Like, it's all gonna blah, blah, blah. And so it's a huge leap of faith, I feel like, and I think the
mhm,
challenge with higher levels of care is that, um there's not a lot of talk about what it looks like and like normalizing that all kinds of people are seeking higher levels of care for different reason,
mhm,
right? Like for residential, I think that's a lot of folks would waver as far as like, well, this seems really extreme, right? This seems like over the top. Like, am I going to be in like a hospital? Blah blah blah.
mhm,
And that's where I feel like it's really important to be like, giving an idea of like what is it going to look like, what are the things that people are typically coming from, and then kind of diving into the conversation of like, okay, and tell me where your life is at right now. Not for the sake of like shaming them, of course not, but rather, sometimes I'll have conversations with people and they're like, well, okay, I'm working and I'm going to school. It's hard, but like I'm able to do it. And for people like that, I'll be like, okay, great. Maybe you should stay at the outpatient level. And like
mhm,
that, if you can manage it there, great.
mhm,
And if it escalates, and then we start looking into like, okay, are you going to school? Are you going to work? Are you leaving the house? For me, it was a pretty clear as day decision. I mean, when I was at the peak of my OCD in 2021, I had not left the house for weeks. I couldn't go anywhere alone. Not I couldn't walk down the street because I was scared that I was gonna have some sort of amnesia episode and jump in front of a car.
right,
So and I couldn't go to stores. I wasn't eating. I was scared. I was allergic to everything. I couldn't even watch TV because I was scared that it was going to trigger some sort of panic attack. Like
mhm,
my life was on hold. It was like I could not function. So for me, it was very clear. Like I need to do this because there's no life. I have no
mhm,
life aside from OCD right now.
sure,
And it can become more nuanced, like the program that I work for that we're rolling out at CU, is an IOP level. So that's 3 days a week, 3 hours a session, so 9 hours of therapy a week. And that's a great
mhm,
opportunity for folks who are like, "Okay, I'm doing the outpatient thing, and I feel like I am white knuckling my way through every day."
mhm,
Like, I might be missing shifts, I might be missing class or not able to do the things I need to do. Great, maybe that's a great opportunity for you to, get some gets put things on hold to pursue this for a short period of time, not all the way up to res, right?
mhm,
Which also comes with financial commitments,
sure,
less so with IOP, but yeah, kinda getting a gauge of, like, how much is this interfering with my life and kinda what matches that, and the willingness to just kind of give it a shot. I think people obviously, when you're signing up for a program, there's a lot of questions, and I think
mhm,
the biggest one that every OCD person is gonna be like is this the right one? Do I even have OCD?" Right? Some of the
of
classics.
course, yeah,
Yeah, it's definitely a leap of faith, so that's why I think it's really important to demystify it and demystify why you might seek this, so
right. That's important, yeah, because we all have different levels of where we're at, and we all have different types of lives, and we our day to day looks different. I feel like I was I would have loved to been a part of something like that when I was in college because it was
Mhm,
really bad when I was in college. But I was just doing 1 hour therapy sessions 3 times a week, and it
yeah,
wasn't any type of exposure or anything like that.
yeah,
So, um, I was going to kinda piggyback off of that. go back to what you were saying earlier, did you also have panic disorder with your OCD?
Yeah, so I like to say for whatever reasons, these disorders seem to be like a buy one, get three free. I feel like it's rarely people just have OCD. So
Yeah,
for me, the things I was dealing with was OCD and then illness anxiety disorder, though in my humble opinion, I think it's really just OCD with health content. But, I'm
yes.
not gonna argue with the DSM on that one, I would say. And then panic disorder were the 3 that were the most significantly impacting me, and they all were intertwined, right?
Sure.
Um, there were certain levels of nuance with, managing panic disorder versus OCD as far as, like, but still doing introspective,
Mhm.
just, exposures, but really the process of, like, how my anxiety worked in all 3 of those was pretty parallel.
Yeah.
Um, but yeah, there's some certain things of, like, to keep in mind when treating panic disorder versus OCD. So,
Yeah, it's good to know because you are right, they do go hand in hand, and I had panic disorder as well, with my OCD, which makes it just infinitely worse
yeah,
when it comes to because now you're afraid of, I mean, just having a panic attack because of thoughts and the
yep,
things you're doing, and, just I forced myself to get out of bed and go to school, and I would white knuckle
yeah,
every aspect of every day, so I understand how tough that is.
yeah, absolutely.
Um, but and to see what you're doing now and helping people in the community and continuing to help yourself, really, because you don't get cured of OCD. It's something that's there,
Yeah,
and you learn how to deal with it and live with it, and to see what you're doing now is well, inspirational to me, but I'm sure that this could also open up a lot of doors for people who are struggling with OCD, are at their worst right now. They may be listening to this and may be interested in going into a field like this in their future, and just something to think about that we really can help people. I'm saying we as in like OCD people, like
mhm,
people who have it. I'm not a medical trained professional, but um, the knowledge that we can gain through our recovery really can make a difference of helping other people recover.
absolutely. I mean, I like to say that I'm like, we never talked about ERP through all my years of grad school. When I went to residential, that was ERP boot camp. So I mean, I learned so much, and I learned ERP by doing it for 2 months every day. And so
Wow.
I think I think there's also fantastic clinicians that don't have OCD out there. But for me, it just made it such a clear path of like, wow, this is something that I didn't know I needed, that I didn't know was going to change the way that I move through the world. And once I found it and really, I mean, I didn't lean into it, I dove. And then I just couldn't imagine then afterwards doing anything else because I was just so, like, fired up about, like, I feel like everyone deserves this. Everyone
Yeah,
deserves freedom.
yeah.
And so, yeah, I'm really excited to be a part of a program also that, we're in network with Medicaid for our local counties, which is pretty much unheard of in the OC field. That's where there's a lot of room for, growth, is that access to care is so challenging. So
Mhm.
really excited to be like, yeah, and we are taking steps in this field to making it more accessible. Because yeah, everyone deserves treatment that's effective, evidence-based, and well thought out. So
Absolutely. And so you have a direct hand in overseeing this program, or you're part of the program and helping develop it? Um,
I'm the OC care coordinator, so I kind of wear a few different hats, like doing the clinical intakes, making sure that folks have outpatient providers, and then running groups. So I'm really excited about the group part. I love running groups. And
wow.
so I'm really excited about that piece. And I mean, this campus is going to be great because, like, the Anschutz campus that we're on with CU literally is a hospital. So we've got like a hospital there. We got children's hospital, like so many exposure
Wow.
opportunities to say the least. So we're ready to
Yeah.
take field trips.
Yeah, those with health anxiety, health OCD and things like
Right.
that, you know,
Seriously. And with the
I should
glass
have.
panels on the fifth floor, I'm like, my Harmony people, like, we just have to get out the elevator and walk to the office, and there's your
Yeah.
exposure. So
Yeah, wow, that's incredible. Well, I really do, as some, one OCD sufferer to another. I don't even like to use the word suffer because at this point it's just part of my existence. But um, I appreciate what you're doing, and I think it's incredible what you're doing on social media and behind the scenes for your day to day work. This is necessary to keep the conversation going, and also to show other people that if they are struggling with these kind of things, that they are most certainly not alone, and they're stepping into a time where we are understanding more now than we ever did about OCD.
Yeah, absolutely, right? And I
Yeah.
think, yeah, like, with content floating around and with the podcast that you're doing, like, I can imagine that a lot of folks, like, even if they just hear one nugget of like, "Oh, that's something that really resonates with me, that I've been through, that I've never heard anyone else say that before."
Mhm.
I think that holds so much power and something that, high school and middle school me was longing for. So I think it's incredible that now people are willing to like share and to have these conversations that for many years were just in my head and very
Yes.
secretive. So
That's
yeah.
so awesome. Well, Allie, this has been great. Is there anything that you'd like to say here on the podcast before we head out?
No, just if anyone wants to follow me on Instagram, it's just Alie, spelled ALIE.Garza. And then also my website is aliegarza.com, which also has links to the clinic that I work for with UC Anschutz. And always happy to answer a DM or answer any questions to connect folks with care. So, yeah.
I love that. Thank you so much, Allie. This has been great.
Yeah. No, thank you so much. So.